Hello, everyone. This is Chris Frederick with the Collaborative Care Collective, and I'm here with Diane Lee, who's one of the presenters at this year's, it'll be 2025 Summit on June 27th to 29th. And you can go to collaborativecarecollective.com to find out all that information, including Diane's full biography. But I'll welcome Diane right now. And Diane, feel free to just say a few words about yourself, who you are, and we'll take it from there.
All right. Hi, guys. I'm Diane Lee. I'm a physiotherapist from Canada, graduated eons ago, let's just say over 45 years ago. And I have worked in private practice in the trenches with patients since 1981 and have been fortunate to work with some of the founders of manual therapy in Canada. And I'm quite passionate about still using my hands in practice, of course, integrated with exercise and education and the pain neuroscience. I lead a team of 15 to 18 people in a clinic in South Surrey, BC, and also teach internationally a method that I call the integrated systems model that has evolved from many, many people's contributions that would take too long to go into. Yes, I'm still working. Yes, I'm still teaching, and I'm honored to be part of this group.
Well, great. So let's start with please explaining how you got involved with this collaborative care collective, which we can call C3 for short.
Well, it came with an email invitation from Gail Wessler, actually. She told me a little bit about what the vision was for this group, and as soon as I read the intention and the vision about having a core group of people who are keen on learning from one another, and also sharing information with everybody from a case-driven perspective. So many conferences are if you don't have data and you don't have research that goes with your experience, you have no voice. And that's what's so different about this group. We have voices, we have many voices, and they are the patients we look after. And I was in right from that moment. I didn't need to meet the people. I didn't need to know anything other than if they had Gail's endorsement, they have mine, because I know her well enough to know that we would be absolutely on the same page. And then when I met the core group, the founding people of C3, man, I just felt like I died and gone to heaven. I found I'd met my people who really had very similar and yet different uh, vision or idea of how the complex, persistent pain patient or the person with complex, persistent problems should be addressed. They should be front and centered. So yeah, it was an invitation from Gail to join this group, and I'm very happy that I did.
So our team of presenters are all highly respected professionals in their own right. They understand the necessity of having a reliable network of others in order to deliver patient-centered care, what we call patient-centered care. And in my interview with Tim and Gail, they mentioned you being an essential part of the team that they initially formed that kind of led up to, Tim and Gail wanting to talk about it on a bigger platform, which is the C3 platform, how we have to work together collectively to care for the patients. It's not any one person, especially when they're challenging of complex issues. So what do they need from you that was a missing element in the complete care for the patient?
Yeah, great question. I was absolutely blown away last year at the first conference at how much they honored the work of Professor Andre Vleming and myself 30 years ago with his PhD research centered around the pelvis and looking at how the joints in the pelvis are stabilized and the evolution of the form and force closure mechanisms. From that work of Andre Vleming's, I then developed a test around the pelvis, which essentially tests the integrity of the main ligaments of the pelvis, which prevent shear between the joints. And you can call it a passive ligament stability test if you like. I call it a form mechanism test. And essentially, it's like the Lockman's test of the knee, where you lock up the joint and you should have no shear capability at it. Andre called it to the position of effective load transfer, where the pelvis can resist loads. Anyway, Don Sandel-Cedi took the IMS series with me, or the ISM series with me, sorry, and so did Gail in the same year. And both of them then taught some physicians in Denver this test, how to truly differentiate whether or not the joints in the pelvis were stable or not. So now they had a test where they could not just guess with prolotherapy or PRP, but they could truly assess changes in the mobility of the joint or stability of the joint with their interventions. And so this form closure test was one of the first things that they learned that had come from Dawn and Gail, from me, from the development, from the form closure work of Andre Fleming. That was the first thing that got them excited about it. And then they started to learn more about ISM, the integrated systems model, which is a whole body approach where you're looking at people who have multiple impairments. It could be that they can't control their pelvis and they can't move their thorax and they've got an old sprained ankle they can't stabilize and perhaps a concussion and a whiplash with dural tension. How are all those impairments related? So ISM really helps you to have a method or a way of looking at the relationship between impairments. So it is about pain, but it's not about treating the location of pain. It really is a function-based model and a function-based program that we teach. And they are very keen on having somebody who worked in this way as part of the whole C3 approach. Now, there are many, many models that look at the whole body. Don't get me wrong. It's not that this is the only way to do it, but they wanted to learn more in particular about the thorax and about, other areas of the body and how they could also in their way. So for the physicians, it was about how can we do this with tools and skills that physicians may have, and how can to determine when remote body areas need to be looked at, assessed, and or treated. So you'd have to ask them why they invited me, but I think those are the two reasons. It was the work that I'd done with Andre and also the ISM approach itself, I think.
So the patient's story is the centerpiece of the treatment philosophy of C3, as well as your own private practice when I did your mentorship training. So can you speak on that, how that drives your integrated systems model?
It is everything. Years ago, patients would come into the clinic before everything was digital with a manila folder this thick of all the tests they'd had, all the things that had happened to them, and your heart would sink because you go, oh, I don't want it. I don't want any of that information. Just let me look at you. I can figure it out by looking at you. And now I would flip that on its head. It's like gold. Give me that binder. Let me take me through this binder. Let's take an hour and go through all of the things that have happened to you, because it allows you to see how not only how resilient the human form is and how many things people have recovered from, what possible shadows may have been left from their experiences they've been going through. And the experiences may not only be physical, they may be relationship breakups, they may be the whole biopsychosocial experience that has led to where they're at now. So you really want to hear the whole patient stories, all of the highs and lows of all of it. And then also what I want to know is, how can I help you? What are your goals? How can we work together to help you achieve the why as to why you are here? Not just what is your problem, but why is it a problem for you, which is what underpins why people come in the first place. We all have pain. We all deal with pain in different ways, but what actually brings you into care? How can I help you? Because without understanding that goal, we have no way of developing a program that that allows you to achieve them because we don't know what it is, right? And so in ISM, we talk about meaningful task. And a meaningful task is related to the person's goal. So if they want to be able to walk efficiently and go for a walk for 5 miles, that's the meaningful task. The why behind it may be because it allows them to get into nature, allows their nervous system to become more parasympathetic. Or it may be social. It may be that they get to go with the girls for a walk and then a coffee at the end of it. Or it could be about walking with the dog. There's many different reasons why people want to be able to walk. But understanding the full story around the meaningful tasks allows you then to help with your motivational, with motivating them to keep going, because sometimes it gets hard. And also celebrate the milestones along the way. And also in ISM, we can't always assess the meaningful task. If someone's meaningful task, for example, is to be able to run, I can't run behind them and see what their thoracic rings are doing, what the head's doing, what the pelvis is doing. So we have to deconstruct that meaningful task down to screening tasks that are component parts of it. So to be an effective runner, for example, you have to be able to stand on one leg. So maybe that's the first place where we start. So hearing the story allows me to understand the goal and the why behind the goal. It allows me to choose what task for this session I'm going to be assessing, because we know from the evidence that motor control strategies are task specific and individual. So if I don't identify from that story what is the task, I may be assessing something that is totally irrelevant to why that person's here. So if I look at a squat for somebody who has pelvic girdle pain, and their pain doesn't come on with squatting tasks such as lifting or sitting, but they come on with when they run for a while, I've totally missed the boat right from the beginning. And I may pick up things that are not optimal, but they may not be relevant to their goal. So it allows us to, the story and the chosen task allows us to keep the patient center in the assessment.
So that brings to mind that practitioners, and I don't want to make a pat statement for everyone, but frequently I'll just talk about my own experience, what I heard from my patients. The doctor spent 2 minutes with me. So who has time out there to listen to patients' stories? What you said, it makes it individualized care, not diagnosis code-based treatment based on the diagnosis only, right? And this is very important. And that leads into, so what is your statement about the current state of medical care in general and in physiotherapy in particular? We're both in North America, you're in Canada, I'm USA, socialized medicine, privatized, but we both of our countries have lots of the public has untold lots of problems that we're dealing with that's sucking away the funds of our governments, right? And our insurance companies. So
yeah, it's a really big problem because the planet, the collective knowledge of the planet is huge. And when you go through medical training or physiotherapy training, we have a lot of skills to treat these people, but we're not allowed the time. Time is money. And so when you are forced to only have 10 or 15 minutes for a visit, whether that's a physician visit or a physiotherapy visit, how can you possibly gain the information that you need from both your subjective or your objective exam to even have a clear understanding of what's going on? So we are limited by time. And what limits time? Money. Money limits time. So in private practice, we have the advantage of choosing how much time we can spend with people. But even that is limited by who can afford you, right? And so when in private practice, we spend an hour of an initial assessment, and sometimes that should be 2.5 hours. But again, we're limited to that hour, right? But an hour for a physician, that's rare that they would have that time. So they need to cut to the chase. And when you are mandated to do that based on the time that you can spend with somebody, the patient feels that pressure and that rush. And they may only tell you about the victim of all the criminals in their body. They may only tell you, my back is so sore. I can't go to work because of my back. But they don't tell you about the ankle sprain and how many deliveries they had and the car accident that mucked up their neck. All of the things that may be feeding into why the low back can't manage these twists and rotations and everything else anymore. And so what does a physician do in a very busy practice when they come in with someone with excruciating pain? They get out the prescription pad and they give them something to numb the pain because that's the tool they have in their toolbox, right? Another physician may pull on a needle and say, well, let's see if we inject some lidocaine in here or some painkiller, see if that makes you feel better. And again, it is addressing the tissue in the body that's screaming the most, but there's no time in that kind of model to ask the why question. And so even when we look at medical disease, liver disease, gut health problems, the treatment is almost it's very disease centered in the sense of, well, you've got this now, let's cut it out or figure out how, we can medicate this or change it. Now, if we bring this to physio, a lot of it in the 70s and the 80s were also pain focused. Let's put this machine on, let's put this hot pack and TENS and other things, and exercise wasn't really part of the whole thing that we did in the 70s or 80s. And the evolution of care and physiotherapy over 45 years that I've seen has been huge. It's amazing. But again, it needs time to fully implement. And when you don't have the skills to really look at the whole person, the whole body, and you've got this person who is in chronic persistent pain, now what we've seen happen is the evolution of the pain neuroscience, which is great stuff.
Mhm.
But in my opinion, it's overused. That if you
Yeah,
can't figure it out, you just send the person to a pain clinic to learn how to deal with it or manage it.
right.
And for some, it's excellent. That's what's needed. But for others, it's not the only thing that's needed. So we need to integrate the pain neuroscience into all of the other things that we know about that could be contributing to the pain song, as it's called, as well. So I think the biggest problem with the medical system and physiotherapy system is time. There isn't enough time in the way our businesses are set up or systems set up. And a lot of that is based on money, unfortunately.
You know, the presenters, yourself and others, all the ones that are presenting, they've all managed to have the right amount of time, more, I would say, than the usual you would get at traditional practices. All of you as presenters, and including myself, I will present as well. We all spend more time than the average of today, I believe. And that's not just to, for our egos or we're better than anybody. It's just that we made that choice.
Yes.
And we decided not to see as many people per hour,
Yes.
because we want quality care. And I think for the attendee, I speak to listeners who are hopefully coming to attend this or want to be inspired. You can talk to us. You can speak to us about how we make it work, because we can make it work
Yeah.
and we get better outcomes with that. And it's a better practice, and everyone's happier in general.
Yeah, it is a choice. It's a choice, isn't it? And you can make a decent income, allowing the amount of time that you need, but you're not going to be a billionaire doing.
No.
And that's business. That's not patient care, right? It's different. And so if money is what is for the clinician, when I interview clinicians to come work for me, if their primary motivator for work is they want to pay off their mortgage, or they want to, it's a good goal anyway, but you know what I'm trying to say. If
Mhm.
money is at the top of the list, I know they're not for us, because
Mhm.
you can make more money working in what I call a physio mill,
Yeah.
than you can working in my place, right? But there is nothing more rewarding and job satisfying than helping somebody um, get back on track, get back their quality of life. That never gets old. It never ever gets old, and it takes time to do that. And I think if you look at the core group, we do a lot of other things. Like if you develop your whole career where you're not just earning money from patient care, but patient care is part of it, but you are sharing your learning and your experience in other ways, either with workshops or teaching. It doesn't have to be on a big grand international stage, but there's other ways to generate revenue from your knowledge than treating patients. And collectively, I think if you were to look at, the revenue each individual one of us makes, it's enough. It's enough.
Mhm.
At least we've chosen for it to be enough. And it isn't 100% coming from patient care. Patient care
Well,
is our lab. It's where things we learn, and yeah,
Well, I
enough.
think
I'll talk to
after
you.
hearing about your inspiring background at first, and then your thoughts about, the current state of affairs, we'd like to be inspired right now. I think our listeners would love to hear about what you are speaking about at the next summit that we're having.
Well, what I've been asked to focus on at the next summit is the thorax. So the first summit last year, my contribution was to explain the evolution of that form closure test and the work of Andre Lemming and myself, and in and around the pelvis. And this year, I've been asked to dive deeper into the thoracic rings and the ribs in the spine, basically, and to see if I can help the clinicians who come, and particularly the physicians to come, to understand why having a compressed, twisted, rotated thorax, and I don't mean just the whole thing, I mean the 10 rings within it, is critical to be able to assess and to be able to treat, and its relationship to pelvic control. So my whole journey and story next June will be to simplify it, dumb it down a bit, so that some introductory tests can be taught and introduced, and that people can go away and know how to find a thoracic ring that's rotated, how to be able to derotate it, and then assess the impact of that on control of the SI joints. So we'll be looking at the relationship between two impairments, mobility in the thorax and control of the pelvis, and how when you change the thorax, many times the pelvic control improves. So that's my goal. The other thing that I'm going to be part of, which I'm really part of, is there's going to be I'm keen to be part of, is a collaborative lecture with a number of us who are going to be speaking on what do we need to get from the patient's story. So we really want to introduce this concept of listening on multiple levels, not only to the story, but listening to tissue, listening to the response to tissue, how manual therapy has changed with the introduction of osteopathic approach of listening, and how we've applied it, many different levels and many different systems. So I'm excited for that one as well.
Yeah, I'm getting all inspired all over again because I know I did not know ribs until I took your mentorship training, that's for sure. And I still have a lot to learn from that. Um, we have patients, coming, or we're doing some troubleshooting live in front of the attendees? Isn't that part of the summit?
Yes, it is.
You
Yes, it
don't see,
is.
you don't see that at other
No,
conferences. You
no,
really
you
don't.
don't.
That's
You don't.
special. Can you speak on that for a few?
Yes. So it's going to start, first of all, it's going to start with, we're looking at the shoulder girdle, right? We're looking at the shoulder and the neck, sort of the upper quarter this year. And there are so many things that influence function from here. And so how do we know when we should start in the pelvis? When should you start with the shoulder girdle? When should you look at the thorax? When is the neck what's causing the problem? So after Dr. Brad Fullerton introduces the conference and the complexity of it, we're going to try to introduce some tests which will show that it's not that complicated when you have a way to assess whether remote impairments are contributing to this. So Dr. Philip Steele and I will be choosing 4 patients, or clients, not patients, 4 people from the audience who have problems in and around this area. And we'll start off by demonstrating some physical therapy tests, screening tests, and Dr. Steele will introduce some tests for physicians, which will inform us as to this person has a pelvic girdle problem that's contributing to their shoulder girdle problem. This person's main problem is the shoulder girdle. This person's main problem is the neck. So the screening tests, and we don't know these people who are coming in, where we're going to be assessing blind as well. At least at this point in time, I think we are. We'll hear their story. They're going to tell us their story. We'll be able to read them. So from the story, we'll pick a few people. And then we're going to bring them up on stage and show them how the assessment, the objective assessment begins. How do we zoom in to what body region needs to be treated to change the impairment?
That's so exciting. Can't wait for it. So if that sounds good to you, listeners, again, you can go to collaborativecarecollective.com. This summit will be in Denver, Colorado, June 27th to 29th, 2025. We hope to see you there. I'm going to wrap this up at this point, Diane. Thank you so much for everything. Some people listen may also want to go to your practice. So do you want to throw out some contact information about where they can connect with you or your staff?
Yeah, sure. If you want to come to the clinic, the website is dianeleephysio.com. And for the ISM education, it's learnwithdianelee.com.
Yes.
And email contact there. You can reach me through both websites.
I'll throw a pitch in for that. Learnwithdianelee.com. Go there if you want to learn from Diane Lee. It's the most amazing training I ever did. And
Thanks, Chris.
End it on that note. Thank you so much, Diane.
Thank you.